Namaskar. Warm greetings to our Fogsi President, Dr. Sunita Tandulwadkar, and to our distinguished guest, Dr. Prashant Joshi. A very good evening to all our listeners tuning into Gyan Pravah, the podcast series. We are delighted to have you join us from across India and around the world. Welcome to episode 278, brought to you by the Clinical Research Committee of Fogsi under the dynamic leadership of Dr. Sunita Tandulwadkar, President Fogsi 2025. ज्ञान का बहता रोजाना एक नया अनोखा रंग हर रात 8 बजे जुड़िए फॉक्सी के संग. I am Professor Dr. Surekha Taire, Chairperson of the Clinical Research Committee and your host for this evening. Today, it's my privilege to welcome Dr. Prashant Joshi, Consultant Cardiothoracic Surgeon from Melbourne, Australia. Together, we'll explore a topic of immense importance, the pregnant heart, managing cardiac surgery before, during, and after pregnancy. It is my distinct pleasure and honor to welcome our very own President of Fogsi, Dr. Sunita Tandulwadkar, a visionary, a trailblazer, and a true architect of transformation in women's healthcare. Where vision meets action, there shines a guiding force, Dr. Sunita. From delivering India's first stem cell baby to leading initiatives like Sampurna, Eagle, and Gyan Pravah, she turns ideas into impact and dreams into direction. An acclaimed IVF specialist, endoscopic surgeon, author, and mentor, she wears many crowns, yet finds her greatest joy in helping others shine.
Surekha, thank you so much. Thank you. This podcast is about Surekha, Dr. Prashant Joshi, and the woman who will need the cardiac surgery. I should say unfortunate woman, sir. I'm very scared of cardiac surgeries, especially the bypass surgery, non-invasive. I'm okay with, but open this bypass surgery, I'm very scared to death. But anyway, sir, I'm so glad this podcast is a dialogue between you and Dr. Surekha. I joined just to show our honor, respect that you have taken out time for Fogsi and came on a Fogsi platform, and you are working for a woman. So we want to salute you.
Thank you.
Living in Melbourne, it's a loss of India, but I think women are women. You can help anyone globally. Though we would have been more happy for such renowned personality to be in our own country. So thank you so much, sir. This is every day, 8 o'clock. We have this podcast series, and it's a different, we never knew that we will cross 260 plus. Surekha, today is what day, which number is yours?
278.
So 278 nights every day at 8 p.m. And I join every day as much as possible unless I'm in the air, just to show the respect to the faculty. They may be from academic, non-academic background, philosophical, political, spiritual, social, and there is so much to learn from everyone, more than my chairperson who are so dynamic, so determined. They come out with such a fantastic faculty, and the podcast becomes so enriched with the knowledge. That I think we, at the end of 360, I don't know what we will be doing. Probably we should do something because it's a good archive we have collected over the year. And but I'm glad that this is open for everyone to listen, not only gynecologists, but everyone. So Surekha, I request you, once you do that, please send the link to sir also. Let him send to all the women across the globe, whatever his friend circle are and his patients, because this is very important information you are going to work on. Thank you so much once more, Dr. Prashant, to be here, as you instructed us not to call Dr. Joshi. And even I don't like to be called. I feel it's little, you moved me away if you call me by surname. So thank you so much once again. And Surekha, enjoy your podcast. Thank you. I'll be listening from the viewers link. Thank you.
Thank you, ma'am. Thank you so much. It is my privilege to introduce Dr. Prashant Joshi, a highly respected academic leader and a skilled cardiothoracic surgeon. Dr. Prashant is a consultant cardiothoracic surgeon at the Victorian Heart Hospital, Monash Health, Melbourne, Australia. Dr. Joshi is a surgeon, teacher, and innovator with over 3 decades of experience and an incredible record of performing more than 15,000 open heart surgery. Let me repeat it again, 15,000. That's incredible indeed, covering both adult and pediatric cardiac care. An alumnus of GMC Nagpur, he went on to complete his MS in General Surgery and MCH in Cardiothoracic Surgery from the University of Mumbai. Before joining Australia, he headed the Department of Cardiothoracic Surgery at Sarawak General Hospital in Malaysia, where he established the region's very first government cardiac surgery unit and trained an entire generation of young surgeons. A fellow of the Royal Australasian College of Surgeons, prolific author and passionate mentor, Dr. Joshi truly embodies surgical excellence, compassion, and commitment to teaching. Dr. Joshi, a visionary clinician, an inspiring teacher, and above all, a doctor with a heart that truly cares. Welcome to the podcast, Prashant.
Thank you very much for this beautiful. I'm humbled and I'm really honored to be associated with your excellent work that you're doing. Leave aside all the other things that you say, but it's really a pleasure of mine that I could contribute a little bit, spend some time with you people. We hope to have a good discussion, and we aim our discussion to patient care today and see if we can improve upon the facilities that you have back home. I do miss working in India, but I do acknowledge that I could contribute more back home. But I did work in a very remote area of Malaysia. I was very fortunate to get an opportunity to work for about 2.8 million people of Sarawak, where there was no healthcare at all, and all tribal people without any cardiothoracic surgical facility. So we did our first open heart surgery there, and you'll be glad to know my name, and in addition to my other friend, our names are there in gazettes of Sarawak state. I feel a very proud Indian to be there and representing some other very, very remote place where people generally don't go. And it was a public service. Yeah, and it was a public service. It was a very basic public work, which I enjoyed. And that experience now helps me in talking to you to compare what the emerging world has and what the developed world has to offer. So we can compare. It will be helpful to people in Sarawak as well as in back home in India. Let's begin with the discussions.
Yes, definitely. Thank you. It's an honor, Dr. Prashant, to have you here. Let us begin the discussion. Dr. Prashant, could you briefly tell us about your journey from India to Malaysia to Melbourne and your experience in cardiac surgery and so in training and supervision?
Well, the journey started actually in India when I was working in a very remote rural area in Loni in Pravah, where I could see that the rural population in India is in need of a lot of advanced medical care. And that time Loni was a small village of 900 some people, and there was a medical college, which was private medical institution. I worked as a lecturer there. That made me think, what would I do if I have got only ambition to become cardiac surgeon? Through the entrance, I then went into medical institute where I got my training, MCH. And then I realized that cardiac surgery actually I started learning only after passing that examination, because I had hardly done any important work skill-wise. So I worked in New Delhi, and then from there, I thought we do need valves, and the valves are not very common in India. It's difficult to get good heart valves because money was so scarce in public institutions. So I thought of learning new technique in Australia, which is called cryopreserved homographs, which human valves that are cryopreserved and then implanted into human beings. Cadaver heart valves are explanted and then they are preserved and then they are implanted. I thought this would be very nice to learn in Australia. So I came here for 1 or 2 years, and I stayed for 4 years in 1990s. Thereafter, I got an opportunity to go to Malaysia because I had a cardiac fellow here with me from Malaysia who said, we will establish a center in a rural part of Malaysia, which will help me in setting some center in India. So that's why I went to Malaysia to work for a year or two, but ended up staying there for 10 years. And I must tell you very honestly that the government system was so good and well-oiled. Machinery was available, state-of-art equipment was given, and whatever equipment, modern state-of-art technology I needed to introduce into theaters was available, and government was very supportive. And I was willing to do as many cases I wanted to. So every day I used to operate 2-3 patients every single day. Myself was accompanied by my wife, who was an anesthetist. So we used to work on the same patient together as a team. And we didn't have any operating hours, like, finish and go home or anything. Our children were looked after by our parents, and they took turns to look after them, and we dedicated ourselves to that unit. And it became a role model of care in cardiac surgery. And then because children grew and I wanted to was willing not to send them alone to any other country. So I had to migrate with them to Australia. So that's the reason why I came here. The work here is totally different. In Malaysia, I did everything from coronary artery bypass to congenital heart disease, neonatal surgeries, aortic work, aneurysms and dissections. In Australia, when I came, we do congenital heart surgeries in very small children, only in certain institutions. So today I do mainly adult and adult congenital work, but I don't do very small children or basic congenital work today, though I do carry other practices and experiences. That's how my journey.
Yeah, it's great. So inspiring and few things to learn. I think one of the thing which struck me as a medical educator and a faculty in a medical college is that you've done MCH 3 years, but still you had to, work more hard because the learning curve is so big.
Indeed.
So we need to really give the message to our students that the learning continues even after a degree like an MCH. You need to have hands-on, and so that's why our students need to learn that. Absolutely. Yes, we need to continue. That is one thing which I got as a message. My son is also a surgeon, so I thought that when you do a general surgery, you do an MCH, still you need to have a hands-on practice.
Oh, yes. Oh, yes.
Secondly, I think the quality of walls, was not good here. The availability was not good, and you had to migrate, and you had the great opportunity to work in a rural area where you did a committed hard work. So that is another thing to, really inspiring, and for students, a take-home message that the hard work put in by surgeons, the long hours, that will give the skills. So that skill acquisition comes through, continued learning and dedicated hard work. So really proud to hear your journey, Prashantji. And of course, we would like to know more about what kind of surgeries or what kind of, common cardiac surgeries which you encountered after women conceived. So whether they were valve replacements or congenital corrections in pregnant women, now we would like to know what were the kind of experience you had with these women, and what kind of indications there are for women who conceive.
Yeah, look, it's a very good question. The experience of doing cardiac surgery in pregnant women was, at the time when I was a student, was available in India itself. Those days in late 80s, rheumatic cardiac disease was a very common factor. And the balloon mitral valvulotomies, if you know them now, they were not yet commonplace. So these ladies who used to come with very small rheumatic valves used to, if they are pregnant, need some intervention because they were in class 4, NYHA class 4 cardiac failure, pulmonary edema, on the verge of dying, oxygen dependent. They couldn't have any cardiac output for the baby, malnourished, small, low weight fetus, used to be in danger. So we used to, in emergency, do mitral valvulotomies. They were closed mitral commissurotomies that time called, and put a TUBS dilator, put a finger through the left atrium, put TUBS dilator, dilate the mitral valve, and get some cardiac output for the mother and baby. That used to be the first experience. They were very commonplace. And a few unfortunate fetuses were, not viable at the end of the procedure. Bleeding used to be a complication. So that was the experience. Lots of cases like that I did. When I migrated to Malaysia, most common, like in emerging world, there is a different need. Rheumatic valvular heart disease was still very common. So I did some patients like that there. However, there is a different sect of patients with Marfan syndrome, dilated aortas, and they are in danger of getting aortic dissections, because pregnancy also puts pressure on blood circulating through the dilated aorta. In Marfan syndrome, the media of the aorta is very weak, so these aortas dissect. Hormonal imbalance also leads to dissection. So these patients get severe life-threatening condition that needs immediate surgery. Now there is a dilemma. If patient presents in full term, it's probably a good news because you deliver the baby and then do the aortic dissection. So both baby and mother are alive. Sometimes you don't have this choice because mother is aortic dissection happened and mother probably is also in danger of dying. Then you have to choose. It's a very, very difficult situation. I had a good experience. I did about 3 cases like that. It's a very big number for one surgeon to get to do a full-term pregnancy and deliver baby and do immediately aortic dissection. And fortunately, all 3 survived with the babies also. I will tell you at the end of the discussion most memorable case, but these are the emergency situations where I operated in patients who were mothers, going to be mothers, and needed heart surgery. And outcomes are different if circumstances are very, very different. And I will talk more when you need to know details about how to plan and what strategies one must have to get good outcome for mother as well as the baby.
Yes. Prashantji, I'm an obstetrician and I have an experience of more than 25 years now, nearing 30 years now.
Very good.
But what I find as a change in trend is previously we used to diagnose heart disease once the women got pregnant, because that used to be the first encounter with any, a doctor for a pregnant woman, especially in India. So we used to diagnose the heart disease once she got pregnant. But now I think with good care, we have women who are not only diagnosed, but the surgery has already happened prior to a conception, isn't it? So we get more patients now who have already, the balloon valvotomy is already done, and now they have, after taking advice from the cardiac surgeon as well as the cardiologist, now they are getting. So this is the change which I have seen over the years, and we are getting more and more women who are getting pregnant after cardiac surgery. So that's a very good,
Absolutely.
paradigm shift which we are seeing.
I am glad, Sureka, you just hit the nail really very in right place. Today, what happens is most of the girls who are undergoing cardiac surgery, not only for the valvular heart disease of rheumatic type or infective endocarditis or anything, but congenital heart disease also, getting more commonly treated, and they are attaining the age of their active obstetric career.
Yes.
These girls who are going to be mothers also are at a very high risk.
Yes.
There is, if I mistake not, in 2017, there was a scientific statement published by American Heart Association for the care of women who are undergoing pregnancy and they have underlying heart diseases. It's I would recommend to every listener to this podcast that they should go and read that. It's a very detailed statement that takes into consideration preconceptual counseling, not just like what to do in control the blood pressure, heart failure, but preconceptual counseling for contraceptive use. They're so important things because these patients who have got prosthetic devices implanted, intracardiac pericardial baffles or Dacron or artificial stuff inside the heart because of the corrective procedures, are prone to get infective endocarditis. And the intrauterine devices of different varieties or oral contraceptives, they have all complications related to their use. First and foremost, the copper T, if it's being used, it can increase bleeding. Sometimes it can lead to infection. Pelvic infections are common. They can lead to the infections on the valve. The prosthetic valves are avascular. They don't have blood supply. They get infection very early. So the choice of contraceptive devices, the oral format of contraceptive devices, they are prothrombogenic. Some cause excessive bleeding. And these patients are likely to be on warfarin sometimes. And warfarin itself has its complication of organogenesis in the first trimester, can lead to congenital defects of the nasal and the oral malformations. So all these things do matter when you consider heart disease, whether rectified or not, and pregnancy is to be taken very seriously. And then you have to have a strategy of how will you organize a team around the patient, a team that comprises of obstetrician, the most important person, cardiologist, and anesthetist if required, if you are putting the patient through a cesarean section or something. Cardiologist is a must. Cardiologist has to be a cardiologist who understands the congenital heart disease, not the adult cardiologist, because these babies and the people with congenital heart diseases are not small adults. Their requirements are different. They have sometimes ventricular dysfunction. Ejection fraction is low. Sometimes it's right ventricular dysfunction. Pulmonary hypertension is severe. And the circulating volume almost doubled, is putting pressure onto their both systems, and patients going to failure just like that without much notice. And that is the reason why I think it's a team approach to build. Multidisciplinary approach is very, very vital in taking care of mother as well as baby and monitor the growth of the baby. I will tell you if we come across the discussion in different.
Surely, I think the preconceptional evaluation is very important. So once they are operated, we have to have a team who will evaluate and will determine what is the cardiac status. So we need a cardiologist. We need of course, the cardiothoracic surgeon has done his job. But of course, the team has to be there to evaluate before advising the patient to go for pregnancy and,
Absolutely.
plan for pregnancy. That's a very, very important, I think.
Yes, Sureka, because the
Yeah.
maternal mortality, sometimes, sorry to have interrupted you, the seriousness of this particular mortality has to be underlined, highlighted. This is one disease component that leads to 10% or sometimes 15% mortality in different classes. There are 4 classes. I will talk about it if you want
sure.
on that one.
Prashantji, how does the choice of valve, whether a mechanical versus a bioprosthetic valve, impact these future pregnancies? And how do you choose when you are doing the surgery?
Oh, yeah. It's a very important consideration. First of all, we have to understand that in a patient who requires valve replacement, first and foremost, the surgeon has to try and repair the valve. Because patient's own valve, if it is repaired, is the best valve compared to the prosthetic heart valve. When we implant a prosthetic heart valve, you're not curing the patient. You are also, remember, you are also implanting a heart valve disease inside of the patient, because this valve needs to be looked after. You need to give this patient anticoagulation, or if it is a tissue valve, maybe this is going to biodegrade. And in 10 or 15 years' time, patients going to need a repeat surgery. When this biodegradation process starts, it doesn't happen just overnight. It gradually happens. That means this implanted prosthetic valve may be obstructive or regurgitant. And if mother becomes pregnant during this deterioration phase, she has got a prosthetic valve there with dysfunctional valve. And then the pathophysiology changes completely. And now you're dealing with regurgitant factor or stenotic factor and the mother with baby at risk. So these things are need consideration. And for that, you need a very good echocardiographic evaluation. Let patient know that this valve is good enough for you to go through the pregnancy or not. So this pre-conceptual counseling helps in that. Determine whether the patient's valve is good enough to last for another year or so without any regurgitation or stenosis, and then tell the patient to go ahead. Until then, that pre-conceptual counseling also includes advice about contraceptive devices, whether implanted subcutaneously. These days, you have devices like that, or intrauterine devices. They have their pros and cons. If you're giving oral contraceptive devices, they are prothrombogenic, because these patients, if they are on anticoagulants, then they will need higher doses of that. So all these things need very, very detailed consideration and advice according to the need.
Yes, surely. You talked of anticoagulation. So how do you approach this anticoagulation prior to the pregnancy, operated patient, and after the pregnancy? Does it change, and how does the change?
I had touched only partly the mechanical and bioprosthetic valves, as you asked a very brilliant question. Now, bioprosthetic valves do not by themselves need anticoagulation as such if patient is in sinus rhythm and if the left atrial appendage has been eliminated by surgeon from inside by suturing it and plicating it. So patient can be on antiplatelet agents and no need of warfarin. If patient is in atrial fibrillation, they still need anticoagulation with warfarin. Mechanical valve, all mechanical valves need anticoagulation for life. Now, if patient unfortunately has got a mechanical valve, in general, we have got a tendency not to put mechanical valves in young, obstetrically active women. We ask the question before to the lady that, are you going to have babies? Are you do you wish for babies? And if they say yes, I would like to have a baby or two, then we generally prefer to let the patient know that, look, it's difficult pregnancy going to happen. If you want to have a baby, then in that case, put a tissue valve. You can come later and have a replacement. In this part of the world, it's not a big problem. But they also did all the, but India, when I was working, was so bad that sometimes patients even didn't afford one first heart operation. They got money, sold, lots of things had to be done before a big, expensive operation is contemplated. So if you tell them right in the beginning that there's going to be need of another operation or two, they would back off. So in that case, this becomes a bit difficult ball game altogether. We need to let patient know upfront that if you're going to be having babies, then we put in a tissue valve, come for the other operation. After you finish having babies, then we put a mechanical valve, and then you go on with the anticoagulation. But unfortunately, this decision is made in a haste, and patient has got a mechanical valve and has to come for, anticoagulation. Then there is a strategy. There are different ways of doing it. First trimester, avoid warfarin. It interferes with organogenesis. The congenital heart defects are very common. Sometimes fetus is not viable because of warfarin and bleeding, and you keep having abortions, frequently. So we don't want that. So you change the patient to low molecular weight heparin, and then monitor. Many patients cannot do it at home properly. So you need a hospital in home kind of care. Nurse will go to the patient's house and deliver that care. Or if patient is educated and can manage it, you teach the patient and monitor adequacy of anticoagulation. That's how you deal with the valve until you reach the pregnancy. And during pregnancy also, there are different decisions to be made, Dr. Surekha. We have to understand that vaginal deliveries are better because bleeding complications and available facilities. Sometimes it's a small city or small town where these cesarean sections are done these days. But this patient, particularly with heart disease, should be referred to a tertiary care center where all the specialists are available to deliver appropriate care, and blood products are required. Sometimes they need to be, prepared for.
Dr. Prashant, I'm glad to convey to you that now Government of India also has this scheme, the Mahatma Phule Yojana, under which all these operation procedures are now free of cost to the women. So initially, like you said, even a single operation, the out-of-pocket expenditure was so huge, they had to sell their house, their land, but now it is not the case.
And I'm very happy to hear that.
Just to convey one more thing, that now the Ministry of Health is also promoting the HDU and ICU in each tertiary care center. So we have a high dependency unit, we have an intensive care unit. So we are able to manage women who have undergone cardiac surgery in pregnancy. So that is the change I see over the years. And I think that's why we are getting good, successful outcomes as well. So
I'm happy to hear that. Really delighted to hear that.
Yeah. And the low molecular weight heparin, which we used to not use so commonly previously, we used to use those unfractionated heparin, but now we are so much used to the low molecular weight heparin that now we have no hesitation at all to, continue and monitor. And so I think that is the paradigm shift in the training and of the obstetrician as well. So I think these are two good things that have happened over the years, and we are able to manage.
Beautiful.
And so about this was all I think about how we manage women who have undergone surgeries and now they are pregnant. But definitely in your experience, you have encountered pregnant women who now require cardiac surgery. So I think that's again a very challenging situations. In your experience, what are the common indications for the surgery? Now, patient is pregnant and now she needs the cardiac surgery. I think very challenging thing.
Yeah. As I said to you earlier, I mean, the conditions that were there in the old days of severe mitral stenosis, is still, but you don't actually need surgery. These days, you can manage the patient with balloon mitral commissurotomy. That has averted a big surgical procedure with risk of bleeding. But there are conditions like Marfan syndrome with dilated aortas with congenitally bicuspid aortic valves, because these patients have very medial tunica media of the aorta is very deficient in certain factors, and then it becomes very weak, and hypertension or eclampsia, preeclampsia, that leads to rupture of the aorta and then dissection of the aorta. This one is a life-threatening condition, and that needs surgery very commonly. And particularly if Marfan syndrome with 4.5 centimeter dilated aorta is on the grade of 1 to 4, the American Heart Association has graded the risk factor for women who are having heart disease or heart condition and they're pregnant, is graded into 4 categories. Number 1 is hardly any risk. The patient has got a treated condition like ASD closure, PDA closure, or pulmonary stenosis treated, or tetralogy phallus corrected, all these things, but normal cardiac function, they don't have much risk. They can undergo pregnancy like any other woman. But those who have compromised status of their pulmonary hypertension, ejection fraction is low, or a heart prosthesis is put inside, they come into grade 2 of risk of maternal or infant mortality. And grade 4 is this one, that aortic dissection comes in. If the woman has got an aorta very big, like 4.5 centimeters, congenitally bicuspid aortic valve, or Marfan syndrome diagnosed, then these are the indications with patients counseling. You need to let patient know that it is dangerous to you and the baby, then abortion is advocated. These are very controversial topics. You don't need to, follow strictly, but they are really very, very risky situations for the women. Now, what happened is all these 3 patients that I got to treat had reported for care for heart surgery once they were at the term. They had dissected aorta, though counseling was done and they were told that you don't undergo pregnancy. They did not listen to the advice, and they came when aorta was dissected. And then what we did was, my first patient, I was working with my wife, Dr. Vaishali. We decided to deliver the baby first. So patient was put under general anesthetic, baby was delivered. And then we watched mother, that there was no bleeding after placenta was removed. Everything was looking good. She was kept intubated. We took her to theater and did the aortic root replacement, which is called Bental procedure. And both mother and baby survived. And then same thing was done for the other patient. The third patient I encountered was here in Melbourne, because I had that experience and I happened to be in hospital. Same thing happened. We delivered the baby. And then immediately during that particular cesarean section, as the wounds were closed, abdomen was closed, we then proceeded with sternotomy, established patient on bypass, and did the operation. There was a patient with pulmonary embolism who was pregnant, and baby was not delivered, but she was going to die. Even there was no time for delivering the baby. In that case, she was hemodynamically so unstable. I just went ahead, did the operation, and put her on bypass, quickly removed the pulmonary embolus. And luckily, you won't believe, she survived. And then baby also was alive. She was monitored during the operation. Baby was viable and baby's heart was beating very well. There is such a big effort that is required in such cases to monitor fetal. Monitoring is to be done. And if you quickly remove the thrombus and baby plays up, the obstetricians take over, quickly deliver the baby as well. But we didn't have to do that in this patient. It was very, monitoring was so good, and patient and
Wow. I mean,
the child.
lucky mother and baby to have you there. I mean, really, it is so inspiring
Yeah.
that you save lives,
In fact, Surekha, you'll be surprised to know this first baby that we did in Malaysia, delivered the baby and then mother underwent surgery. The child was named Joshi
Wow,
after
so
me.
lovely. I know once I operated on a patient who was an arcuate uterus, and she had number of previous abortions, and then under my care she could, go through the whole 9 months, and then I only, named the baby Hridayanath, because he came from a heart-like uterus. So I know these moments are, I think, the real achievement and real joy for a surgeon, an obstetrician, a doctor, when we get those, small, these are gifts, I think, and for us, and lovely moments to remember. So congratulations. I think it was really wonderful to hear your experience about 3 patients, and I get the answer for the challenges as well. But one thing, we always listen to in Bollywood movies, माँ को बचाना है या बच्चे को. So how do you balance between the mother and the baby when you are intraoperative? There is a challenge. So how do you decide?
Oh, that is mother first, of course. If you have to choose only one, but entire team works for both. You have got a very good team approach, then they work for both. And you already know, being an obstetrician, that you can deliver the baby 5 minutes, even if you want to do a cesarean section. So that's not a big thing today. You can deliver the baby very quickly and get aside. But this rupture of the aorta, when that dissection happened and the obstetricians were doing here in Melbourne, then I had told them to prep the entire field completely, so that if I need to go and cannulate the patient, I should be able to do it immediately. They did their job and they said, "Can we hang around to watch?" I said, "No, you finish the job and go." Because
great.
Because patient is going to be heparinized. So their stitching has to be very good, because patients cannot afford to keep bleeding, because this operation of aortic dissection can go on for 5 to 6 hours in a row. And the patient is fully heparinized with activated clotting time beyond 450, 500 seconds, which is, blood has no clotting tendency at all. It keeps flowing. Like you see ectopic, what you call not ruptured ectopic, but the placenta previa, the bleeding that happens.
Accreta also.
Yeah.
We are commonly encountering the Accreta syndrome, where the bleeding is so huge.
Yeah. So that type of bleeding happens around that dissected aorta. But uterine bleeding doesn't, I have seen, and I was scared. As a cardiac surgeon, I've seen bleeding so many times. But when I saw that, I was scared myself. That, my God,
it bleeds like a tap, as if you've opened up a tap. It's huge, and it is scary. It is scary indeed. So, but I think you have been fortunate to have an anesthetic wife in the team, because the challenge, the intraoperative challenge, is not only for the surgeon, but is also for the anesthetic team. So I think
very famous line, Surekha, for that. I always keep telling my fellow friends in the hospital, that I love anesthety so much that I keep one at home all the time.
Yes, definitely. Yeah, I have an anesthetic daughter-in-law, so I know her importance.
You're lucky.
Really, yes. So of course, we have listened to your illustrative case also, and wonderful to hear the success for both the mother and the child as well. So let us know about how the cardio obstetric care is structured in Australia compared to India or Malaysia, and what could advise some recommendations for improved care back home here.
I am thoroughly impressed by what you just said, that the facilities are far different from when I was operating. I was doing my training in India. It's very happy to know that if at district level, such high dependency units, monitoring devices are available, then that's the best. Here in Malaysia, we had very big state of Sarawak, huge state, had very scattered population. Density of population was around 15 to 20, very jungle Borneo, and people from remote areas used to come very, very sick, and sometimes only when they need real care. Otherwise, they home deliveries and everything. So no facility like what we're talking in books existed on ground. But in cities, yes, big hospital, tertiary care units where heart surgery, cardiology, and the pediatric cardiologists are available. Then we had all a multidisciplinary team approach in our hospital. So the patients will come from periphery and they will be admitted for 2 months, 3 months, in the hospital until the delivery goes smoothly. In Australia, it's a totally different place. When the mother, people evaluate congenital conditions have been treated for a long time in Australia. So Roger Mee was a very big name in the world of pediatric cardiac surgery when it was being done, and in the best possible way. Melbourne was the place where it was done like anywhere in the top class. So there are already patients who had undergone corrections for congenital heart diseases are grandmothers already. So,
wow.
Yeah. So this is very oiled machinery here, wherein when those patients grow, they are told that if you undergo pregnancy, this is going to be a very special care area, and you need to plan your pregnancy, and you need to first of all see your cardiologist, obstetrician, and then stay in touch with it. Here you get GP is the mainstay and who guides all these things and creates a team. And then this team is built around that mother to continuously monitor, do the echocardiograms regularly, monitor the growth of the baby. And if patient needs intensive care admission and then planned seizure or something and needs central monitoring, the Swan-Ganz catheters and everything, monitoring is available, and then admitted in the hospital like ours, like we have at Monash. So only certain centers that are reputed, they are given this responsibility to look after the mother. This delivery will not be conducted in periphery. This patient will be asked to migrate, stay in closer to the tertiary, because they can go into labor anytime.
Anytime.
And then cardiac failure sometimes happens slowly, but sometimes if precipitous things happen like that, you need to have a tertiary referral center very, very close by. So they are encouraged to move closer to the hospitals, and then the deliveries are conducted.
Yeah, I have a very, I just remembered one case when I was working at Savangi Medhevarda. There we have a very good cardiothoracic unit and a cardiologist as well. We had a patient, just briefly, I'll let you know that she was told everything. She knew her condition. She knew she had to be near the hospital and all. But in India, the pregnant woman will go to their maternal, mica for the pregnancy. And she was living with her old parents, and she knew that she had to come very early. But when she had breathlessness, she knew she had to go. But she waited for her husband to, travel from some village, and we lost that 4 5 hours. And that is, I think, what we really need to educate not only the patient, the parents, the couple, the husband, the in-laws, everybody. So because those 4 5 hours did make a difference, and we did
It
not
does.
have a yeah. So these are the things I think we need to change, especially in India. We do have good surgeons now. We have the intensive care unit, but the mindset of the patient, the couple, the relatives, I think the attitudinal change, that is what needs to happen.
Absolutely.
Yeah.
Mother's education, mother needs to be emphasized that this is not going to work if you are going to be somewhere else. It's not going to be effective. We're taking all this care so that the baby and you are safe. You don't do anything else. First thing is his particular baby and your good health. So that has to be a priority, and that has to be told in no indistinct terms.
Yeah, repeated again and again.
Absolutely.
Yeah. So, Prashantji, I was really, when I looked at, when I was reading your CV, 15,000 surgeries. I mean, that's a record breaking.
No,
So,
no.
out of these 15,000, how do you, one single case, if you can illustrate to us, which impacted you not only professionally, but personally as well? We always have that one, story to tell. So can you let us know about that?
Oh, there are so many. For patients with congenital heart disease, I just already told you about the aortic dissections that I did, and pulmonary embolectomies I did.
Yeah. Those are really, I just, remembered my patient. When we say pulmonary embolism, we always think of that. Now she's going to die. And when you said we did the embolectomy and she survived, oh my God. So
Yes.
that really is important.
Yeah. I mean, not only that, this particular mother that survived with the baby came to see me about 6 weeks for a follow-up. When she was brought in, that time, entire team was in emergency situation where there was no other thing but quickly shifted to theater, and I had to put on bypass and take that clot from. When I started pulling the clot, it came out a meter long clot, coiled, because it came straight from IVC into the heart and blocked the pulmonary artery at this saddle thrombus. Generally, it doesn't happen, but you know that in pregnancy, women full term cannot lie down on their back supine because they become symptomatic. So they lie on one side. The moment she did that, she had walked, and then, there was a clot. She was very thrombogenic. Probably she didn't take heparin. She had already had DVTs and heparin prescribed, and she missed the doses, and there was a big clot. And the moment she went to the toilet, came back, and couldn't lie down supine, she turned to one side, and that's it. There was no blood pressure. She just arrested. She was brought to the hospital resuscitating, and when she was in 10 minutes brought to the hospital with massage going on, shifted to theater, I had to say mother. So I went and did that, and then put on bypass. Then people told me that fetal heart sounds are okay, fetal heart sounds are all right, baby's okay. So I said, just quickly remove the thrombus, and then kept her on bypass. And then obstetricians delivered the baby, and then I closed the wound. And
it must be heartening to find her back in the follow-up.
Then I went to intensive care unit, and then I said probably she won't wake up because the downtime might be very long. But she opened her eyes when I called her name, and then slowly in 2 days' time she was extubated. And then when they showed her the baby, she was crying. And then 6 weeks down the line she came, and she had forgotten a lot of things, and staring at me who am I? I said,
Oh my God.
I don't want to.
Many a times they do remember, and many a times I've seen, my experiences, villagers, they'll bring oranges for you.
Yeah,
एक भाकरी घेऊन घ्या आमच्या घरची. So these are, I mean, really wonderful moments for doctors to remember. It is not about the earning the money, it's about earning this respect, earning these moments for us to, remember throughout our lives. So it was really memorable. I mean, wonderful to listen to you, Prashantji, but only one last take-home message from you for the young obstetricians and cardiologists. How do you think as a trainer they should understand the pregnant heart better? What would be your take-home message for these youngsters?
First of all, as I said to you, I think they are very good in what they do. And sometimes they have to be prepared to take on some challenging cases like that. And what was going to improve the outcomes for mother and baby? This is one condition of all the conditions that a pregnant woman can face. That is, offers very, very good outcome if a team approach is sorted out right in the beginning. Multidisciplinary approach. When you know a girl who has corrected congenital heart disease or valvular disease, then you need to treat this mother as the very precious mother, and all the attention that she can be given is not enough. That's what one has to tell oneself. And then what can we do? The best thing we can do is to get a best team, the team of good caring obstetrician, cardiologist, anesthetist, and plan for the delivery of care, monitor growth of the child. Sometimes congenital heart diseases, cyanotic type, untreated, they are pregnant. Eisenmenger treated with pulmonary hypertension are pregnant. Very, very high risk situation, 10 to 15% mortality. But both can be saved if you organize team around the mother and make sure baby is monitored, mother is monitored regularly. Subtle signs of heart failure, don't mistaken. Edema feet is not always because of venous congestion here. There's a cardiac failure coming in. You can't do many times x-rays. Listen to the lungs. Listen what is happening, how short of breath. They are always short of breath because the diaphragm is pushed up, but they can't tolerate the heart failure properly. You need to know, do the echocardiogram. That's the non-invasive investigation. Find out what is the cardiac output, what is happening. And then if still baby is growing, encourage vaginal delivery if possible. If not, then prepare for cesarean section. ICU facility important. Swan-Ganz monitoring if required is important. Anesthetic care is absolutely vital. Bleeding can happen, so blood bank is to be notified. Absolutely important thing, a vital thing is to have good blood ready if cesarean section is unavoidable. Plan it during daytime. Plan these pregnancies as first in the day, not towards the fag end of the day after obstetrician does 7 cases and then the 8th one is coming like that. No, this has to be the first patient on table. All these things are minor things, but they're absolutely important and yield excellent outcomes to the patient and the baby. And it's very, 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 very rewarding to have a very good outcome.
Thank you. It was really wonderful to listen to you, Dr. Prashant. And sometimes, over the years, youngsters nowadays are questioning whether we should go for medical as a profession. But if youngsters listen to you, this podcast, I think they will still, we would still prefer, because I myself, obstetrics is very challenging indeed. So I always think, if I have been given a choice, would I become an obstetrician again? Similarly, if youngsters listen to you, they'll definitely want to be not only a medical professional, but a surgeon like you. I think you inspire minds, young minds, because, they say that doctors are God, but not many a times now people question, but if we listen to you, we do feel that yes,
Thank you.
doctors,
I'm humbled.
God comes through doctors number of times. So thank you very, very much for this very wonderful, enlightening episode of Gyan Pravah. I would like to extend my heartfelt gratitude to you, Dr. Prashant, for sharing your remarkable journey and deep insights into the world of cardiac surgery, reminding us how science, skill, and compassion come together to heal hearts and save lives. Special thanks to
Thank
Dr.
you. Pleasure is
Sunita.
mine. Thank you.
Yes.
Thank you very much.
Special thanks to Dr. Sunita, who is our President Fogsi, whose visionary leadership continues to inspire and empower meaningful dialogues. Also, would like to thank our listeners. Thank you for joining us today. Your curiosity and commitment to advancing healthcare keep this conversation alive and purposeful. Stay tuned for more thought-provoking episodes of Gyan Pravah. I am Dr. Sureka Taire with Dr. Prashant Joshi would like to sign off. Until next time, keep listening, keep learning, and keep your hearts open. Take care.